call upon Dr. Rani Balamuralikrishnan. She's the medical superintendent of Amadeep Hospitals. Let us see what she has to say about the dissatisfied patient. Is the most common scenario of cataract surgeries, which every one of us face.
Good morning, all. The topic is still blurry post-cataract surgery patients. So these are the common complications which occur after cataract surgery. All these complications can lead on to an unsatisfied patient. So reasons can be clinical and others. The technical imperfections from anesthesia to prescription of glasses, systemic illnesses and other ocular related illnesses related to the eye. Then if you have done a technically perfect surgery, the patient may be still unhappy about vision. The moment they step into a hospital and throughout the visits and whenever you meet the patient in social gatherings, they'll start complaining. So these are the technical imperfections which you usually face from anesthesia, and all the surgical complications. There are certain expected ones in case of pseudoexfoliations, subluxated lenses and posterior polar cataracts, retinal and choroidal diseases. Then unexpected things also happen like PCRNs, wound burns, leaks, sutures, nucleus drops, recurrent uveitis, retained lens matter, descented IOLs, endophthalmitis, refractive surprises, etc. So these are the other illnesses can also have implications in the eye. That systemic disease like diabetes, hypertension, even dementia, terminal illnesses, etc. cause ill health and malaise. Then ocular diseases like glaucoma and other retinopathies, corneal diseases, retinal degenerations, optic neuropathy and so on. You've done a technically perfect surgery but the patient is unhappy. This can be because of the drug allergy, intolerance and epithelial toxicity, either a wrong prescription or an anisometropy you have created. And in monovision, the patient may cover one eye and say that the other eye they are having blurred vision. Contrast sensitivity issues, especially following multifocal IOL implantation and dysphotopsias. Then there can be non-visual complaints also, they like dry eye syndrome, foreign body sensation, ptosis, lid edema, subconjunctival hemorrhage, and experience at your hospital. So when you expect technical imperfections, how will you proceed? So you have to convince the patient. The discussion, you have to give a little chair time with the patient, understand the expectations, clarify them regarding the additional procedures like 3-piece IOL, anterior vitrectomy, etc., iris hooks and all. Then about the residual errors and need for glasses and contrast sensitivity issues in case of multifocal lenses, about the working distance and the implications of the associated illness. Your plan should be discussed and recorded. You have to give leaflets, as she said, and make them read and sign before making the decision regarding surgery. Counseling should be done at trained personnel. So a counselor is preferred. That the person should be trained for cataract surgery counseling and should be good in understanding the psychology of the patient and the expectations of the patient. All discussions between you and the patient should be conveyed to the counselor. And they should discuss about all types of surgeries, lenses, additional procedures, complications, the amount incurred also. The money matters should not be discussed by the doctor, it should be by the counselor, because patients always expect doctors to be not money-minded. And these are the technical imperfections. When complications happen, you have to manage it properly. If you're not able to manage, you have to refer it to your seniors or your colleagues. So you have to discuss immediately after surgery, confidently. There should not be any panic and with a calm face. And when the patient comes for the second visit, you have to reduce the waiting time. You should not allow harming discussions with other patients and the staff. So this is another refractive surprise. This also you can eliminate if you know the expectation of the patient. And there should be an experienced personnel for biometry. They should do contact, immersion and optical. And they should know when to repeat the biometry, and they should know to compare with the previous IOL power and other eye, refractive status of the other eye, and they should be able to do the online calculators. You personally have to verify all the biometry values prior to deciding the IOL power. If any refractive surprise arises, you should reassure the patient. In some myopic errors, the patient may be able to cope up with the glasses later on. If they are not able to do that, then you, if required, do the IOL exchange or a LASIK. In case of residual astigmatism, realign the IOL and do refractive surgery. And you should counsel them regarding the glasses, and the informed consent should be there. So if poor quality of vision, even if there is a good visual acuity, this can be due to dysphotopsias. So these are unwanted optical images. A positive dysphotopsia occur in presence of light, the glare, halo, starburst, etc. Mostly for presbyopia correcting glasses. So a counseling is needed prior to that, or you can offer EDOF lenses. And in the immediate postoperative period, due to the wrinkles and striae on the posterior capsule, and when the haptic tip exerts pressure on the PC, and this may disappear as soon as the capsular contraction occurs. If not, you can do a YAG capsulotomy. In negative dysphotopsias, this is a temporal arc of shadow, especially in patients with good postoperative visual acuity. It can be multifactorial and is said to be due to an illumination gap between the IOL in the back and an empty periphery, causing a retinal shadow. You can reassure the patient this will disappear with neuroadaptation. A thick frame glasses will also help to attain neuroadaptation faster. If 99% of the people will recover in 2 to 3 months' time. If not, you can do a reverse optic capture to defocus the illumination gap, a piggyback lens in the sulcus, and limited success is attributed for the nasal YAG, anterior capsulotomy, etc. In case of contrast sensitivity issues, you have to counsel the patient and set expectations. And if they are not able to cope with the multifocal IOL, you have to explant and exchange it with a monofocus lens. Then other visual complaints may arise due to drug intolerance, epithelial drug toxicity. Then you have to alter your medication regimen, use preservative-free drops, and frequently use lubricants and ointments. Most people will recover in a few weeks' time. If not, you have to investigate for ocular surface disease or stem cell deficiency and get an expert opinion. For wrong prescriptions may be corrected and verified before dispensing. Then ptosis, and these days because of we are moved to the local topical anesthesia, these lid edema, ptosis, anesthesia, myotoxicity, etc. less. They are transient and improves over time. If there is elevated dehiscence, it requires surgery. So you have done an expert surgery. More than just providing an expert medical care, experience at your institution, as Grishma said, that's very important. You have to minimize the waiting time through introduce appointment systems, ensure clean environment, comfortable waiting areas, minimize the paperwork, use online facilities, make faster clearance of insurance related papers, engage employees for personalized eye care. You have to implement newer technologies, QR coding, etc. in the waiting areas for registration and feedback, announcing systems and displays. So you have to evaluate, you have made your system right, but you have to evaluate it again. So if frequent problems come, then you have to do a clinical audit and find out what is the reason of the problem and rectify it. You may get more information than you expect. So then is a medical records audit should also be done for recovery of data and for your studies and for medical legal purposes. Then patient feedback also helps you a lot. So once you have done all the systems right, then you have to do a self-audit of yourself, continuous outcome monitoring, do systematic and regular review of your own surgeries, identify the gaps, compare with the best hospitals and surgeons, and implement lessons learned from peers. Your approach should be aim for technical perfection, anticipate complications, do conversation with the patient, training your co-workers for perfection, and self-assessment. Thank you.
Thank you, Rani Madam, for that detailed presentation on how to manage a dissatisfied patient post-cataract surgery. Thank you so much.